Well, you guys are getting an amazing amount of information. I hope you're writing down all your questions. Kyle Fischer is an adjunct assistant professor and the director of health policy and leadership fellowship program at the University of Maryland School of Medicine and in the Department of Emergency Medicine, if you can note a theme here. He also is the director of the policy work group in the National Network of Hospital-Based Violence Intervention Programs and is a member of the steering committee.
Thank you, Joel. Thank you so much for having me here today. I'm so honored to be here. There are a lot of people on the stage and in the room that I really look up to, so I'm just grateful to be here. I'm going to talk today a little bit about the state of the science for hospital-based violence intervention programs, research and policy implications, because like Joel said, I'm a policy guy. I'm always going to pivot there. I'm an ER doc at the University of Maryland and work at the National Network for Hospital-Based Violence Intervention Program. So, a little bit of background on what HVIPs are. I'm glad that it came up a couple of times already, but I'll just reinforce it very quickly. HVIPs combine brief in-hospital intervention with intensive community-based case management and provide targeted services to high-risk populations to reduce risk factors for re-injury and retaliation while cultivating protective factors. All right, so what does that mean? That's a lot of stuff. It means someone comes into the hospital, they have been violently injured. We need to take care of them in a team-based approach for much longer than when they get discharged from the hospital, because the trauma starts both before and after the injury, and there are a lot of things that you need to do to make sure that people heal. So how does this work? For an illustration, if you notice, you'll see that I'm generally a very minimalist in my presentations, and this looks like a complicated slide, and that's because violence is complicated. This is on purpose. So in the very middle, you have the injury. The injury is both physical and psychological. You cannot have physical injury without psychological injury. But that doesn't mean that before the injury, there wasn't other trauma in that person's life. So substance abuse, neglect, physical abuse, exposure to violence, household dysfunction, those adverse childhood experiences that we've heard mentioned before. These are things that existed before the patient is even injured. And if you think about after the injury, there's no reason to think that they've gone away. So they're probably still there as well. So how are you going to get this person to fully heal after an injury when you have all of that going on? There's lots of things that could push people in the wrong direction, some things that could push them in the right direction. So worries of retaliation, worries about using substances to self-treat, dealing with post-traumatic stress disorder can all be challenges. Whereas if you offer services, if you offer support, mentorship, case management, perhaps you can get someone to a full recovery. The way that we think about doing this in the hospital-based violence intervention program approach is it takes a team. One person can't do it. So in the middle of this, you have the patient, and the rest of the team, you might have a doctor, a case manager, trauma nurse, social worker, counselor, and then you have highlighted our violence prevention professional. This is the most important person on the team. This is the engineer that does all the work and makes sure that everyone comes together to make sure things happen. These are folks that we try to hire from the community, oftentimes have have a history of violent victimization themselves, and are able to talk to the patient in a mentorship relationship and translate everything that everyone else on the team is saying to make sure that it actually happens. So, with that in mind, let's go through the HVIP research, and I'm going to try and highlight some of the biggest, most recognizable trials that you may have read about that get kind of highly cited. Before we can get into that data, though, we need to look at what happens if this doesn't happen. So like Dr. Cunningham mentioned before, in most of the country, the standard of care for someone that is violently injured is they get stitched up and discharged, told to follow up with your primary care doctor or trauma clinic. Does this work? We all know it doesn't. So this is data adapted from Michael Green, who's a criminologist at Rutgers. He did a systematic review of 19 studies that looked at rates of repeat violent injury. If you noticed, on the far right side is the highest 62% were re-injured. On the far left side is the lowest, only 8% were re-injured. In the middle, most of them fall in around 25-30%. So if for any other disease where someone had a potentially fatal injury and about 1/3 of them or 1/4 of them were going to re-experience that in the next couple of years in otherwise healthy people, we would be on top of that, but we are not with violence prevention. So with the National Network of Hospital-Based Violence Intervention Programs, that's what we're trying to reverse. So what if we had HVIPs? I'm going to kind of lump this, trying to go up our pyramid of evidence that some of us have learned from public health school. So we're going to start out with the observational trials. At the bottom, because I think it's very difficult to understand, observational trials without something to compare it to, I just have some of those numbers from the Green trial or his systematic review. I know that, from a research methodology perspective, it's not apples and oranges, but you need something to compare it to. So remember, for the Green review, the lowest he found was 7.7%, and the median number in the middle was 27%. So there are 3 evaluations I've included here. I accidentally meant to do 2, but I'll comment on that in a second. The first is Bell. So she's a researcher from a program up in Indiana. I very much like this trial because, as some people know, Indiana has a very robust statewide health information exchange. So they were able to track something like 500 of their patients across time and see where people were, no matter where they showed up in the state, because of this robust health information exchange. Their re-injury rate was around 4.5%. Juilliard, that's a trial out of San Francisco General. This was a 10-year evaluation of the effectiveness of their program, and they also came out around 5% for their re-injury rate. And compared to historically before that, those numbers were closer to 8%, so about a 30% reduction. My brief error is when I was coming through all of this, I didn't want to do any duplicates or any updates of trials, but the Smith trial I accidentally put on. This was that same wraparound program in San Francisco, but a couple of years before. So it's a lot of the same patients, but at an earlier time period. And at that point, the re-injury rates were about the same, but they had higher baseline levels of violence at that time, and their re-injury rates in 2013, when the study was published, was 16%. So they still did just as well, going from 2013 to 2016, but rates of violence in the community are always going to change depending on, economic factors, social factors, all sorts of things. So moving up, there's one retrospective cohort study that was published in 2007 by Subaru. This looked at 154 youth between the ages of 12 and 20. Most of them were about 17 years old. And if you notice in the intervention versus control groups, there wasn't a tremendous amount of difference. There's no statistical difference there. So looking at specifically at re-injury and death, in 2007, they didn't find as much difference. There's lots of reasons why this could be, but I'm very happy that Dr. Leavis presented before me. And I think when you look at what they've been doing at UGMA, it really shows that 2 things. One, it's a lot more than just about re-injury and death. There are all of those other things happening in the person's life, in the child's life, that are important. And 2, in the story of Jason, you notice that there's something of a ramping up period with him. I think it's a great example. Jason, if I recall, his first injury was at age 8, had another 2 years later at age 10. This was an 18-month follow-up. And then a couple years later, had his first stab wound, and then very quickly it became a gunshot wound, and then the next year death. So does this fit in with the trajectory of what you would expect for a younger patient population? So there are 2 pediatric randomized control trials that were published around that same time period in 2008. I do want to note that both of these, they come up in the HVIP literature a lot, so I felt compelled to put them in here, but I'm not sure that they really meet our current definition of what HVIP looks like. The interventions don't have the complete level of services and interaction that they're doing at UGMA and some of the other sites at CHOP. And 2008 was before the NNHVIP was formed, so it was before some of these best practices were formed. But you will see this data a lot. So there's the mentor-implemented program for assault-injured youth. They did show that for fight injuries, these kids were a lot younger also. These kids were 13 or 14 years old in both of these trials. For the intervention group, 5.7%, control group, 7.8%. It was not statistically significant. And for the second trial that looked at if you put a case manager on a kid, does that make a difference? 45 kids in each group. Parental and youth report for both intervention groups showed that it was perfect. For the control group, 14% of parents said that there was a fight or an injury, 8% of youth. But it's a little hard to know what's what when you kind of look at all of that for the same reasons I mentioned for that slide before. So pediatric, I think we still need a lot more data, and the work that they've been doing with Dr. Levis and some of the other groups, I think is really going to shed a lot more light into what matters for kids. And there's a lot of difficulty with kids too. So one very common difficulty in doing randomized controlled trials is a lot of IRBs do not think that they're ethical, right? So the idea that you would take one group of 13-year-old kids and give them an intensive intervention with case managers and social support, and the other group of kids, you'd hand them a pamphlet of places to go to, that doesn't sit well with a lot of places. Most places, I don't know about most, but many IRBs find that unethical and will not approve those trials. And in fact, for some of the observational trials I mentioned before, that's the reason they were observational. So let's get to the adult RCTs. So there are three that come up the most. One is from Dr. Cooper, who I see in the room, published in 2006. That was up at Baltimore Shock Trauma. Intervention group getting HVIP services, 5% re-injury, whereas the control group, 36%. The second study was from Les Zun. He was an ED doc in Chicago. Had 8% re-injury, control group 20%. And then the third trial is Dr. Abutanus, who's at VCU in Virginia. This trial did not show any significant difference between the two groups. It was a small trial. There were a lot of quirks to it. It's hard to interpret. For example, a large segment of both groups came into the trial already with papers and were going to be going to prison shortly thereafter. So there's some quirks to the trial. It's hard to interpret. But I do want to mention, so when you look at all of these trials and think about them with the green data in mind, so the green data showed that median 27%, the lowest they found was 8%, and with our observational trials, our RCTs, all of them, those numbers are lower. So we still have a lot more research to do. None of this research is perfect, but things are looking promising, and there's a lot of places to fill in the gaps, but right now I'm very encouraged by the data. Right now in the city of Philadelphia, they're doing a very large step wedge trial out of the Healing Hurt People program that hopefully should be able to provide, hopefully I hope, the most definitive data yet on the effectiveness of our programs. So, like we mentioned before, though, this isn't all about re-injury and death. So We care about the social determinants of health, mental health, substance abuse, service delivery, patient experience. These are all things that are very, very important, and they are peppered throughout the HVIP literature. There isn't any one place that has really done, one paper on HVIPs and their effectiveness on the social determinants of health. But when you look at each study, they all kind of touch on it. So I'm just going to talk briefly about a couple of these areas. I think the best example of this is when you look at Dr. Juilliard's paper on the 10 years of the wraparound project. For some reason, buried at the end is a table where it looks at the most commonly needed services in the 10 years that they did the study and who needed what and how often were they able to deliver it. The most common service was mental health by far. It was over half. And they reported that they were able to meet the patient's needs in 85% of those patients. So this is an area that in 20 minutes, I can't get to it. It's a lot more scattered, but it's an area that I do think more focused research on really delineating this in a very obvious, easy-to-read format that's easy for people to take a look at and come away with the answers is going to be helpful. So for anyone that's met me knows that I love health policy, so I'm always going to pivot there at the end. And I want to end with a pitch for health service research on this area. So if you recall, our patients, especially in peer violence or youth violence, traditionally have been uninsured. If they're not uninsured, they traditionally have Medicaid. And Medicaid, our eligibility has changed quite a bit over the last couple of years, and we've changed our health system. The Affordable Care Act was a landmark piece of legislation that lots of people have different opinions on, but it has changed things. So the biggest thing that I think is really important for us all to think about is the Affordable Care Act's Medicaid expansion. This Medicaid expansion is young adults who earn less than 138% of the federal poverty level. And if you think about it, these are our patients. These are our patients. And it's this very odd situation where if you think of any other disease, cancer, heart disease, it really doesn't, pick and choose what kind of insurance you have. But for some reason, because of the demographics of violent injury, our patients are mostly Medicaid patients. So we need to think about that, especially when we think about sustainability. So this next slide I have used with the permission of Dr. Coupe, who looked at the changes in health insurance status per year. And all you need to know looking at this slide is that in 2014, that last graph, that was the first year that the ACA Medicaid expansion was implemented. And from the year before to the year after, 9% of people went from being uninsured to having Medicaid. So it went from 30% to 40%. That was in 2014. That number will continue to rise as states begin to adopt Medicaid. And this is something that we should be thinking about as an avenue of which that we can help pay for our patients to get services to help them heal. Before the ACA was implemented, myself and Dr. Ted Corbin and Dr. John Pirtle up at Drexel, we started thinking about this strategically because another quirk in the demographics is a quirk in the payment system. So for folks that aren't as interested in Medicaid as I am, generally Medicaid is a cooperation between the states and the federal government. And across Medicaid, the states pay for half and the federal government pays for half, although that number changes, depending on your state a little bit. With the Medicaid expansion portion, the federal government pays for 90% and the states pay for 10%. And the states have a lot of decision about what services to cover. So you have this odd situation where the states have the opportunity to cover additional services that the federal government will have to pay $9 out of 10. We did some modeling, and before the ACA went into effect, we found that based on the existing literature, states could go ahead and find that implementing HVIPs would be cost-effective and perhaps even save states money. Having said that, it was preliminary data. It's not the gold standard of any sort. I hope that someone repeats our study with actual real data now that it's actually happened. So with that, I am done, and welcome any questions in the intervening section, and all of my references I noted are there. Thank you.
Thank you, Dr. Fischer.